بسم الله الرحمن الرحيم. أهلا بيكم أبنائي وبناتي طلبة ال Competence Based Medical Bachelor Program of Tanta University في Neuroscience 2 Cases Revision. معكم بروفيسور أشرف أبو الصفا Professor of Neurology Tanta University. We have to be familiar with the clinical case scenarios and to know the systematic appropriate approach for some clinical cases and to follow the proper logic scientific steps in diagnosing clinical problems. We have today 4 cases to be discussed. The first case, a 28-year-old previously healthy woman comes to the physician after suffering loss of vision in her right eye that resolved within a few hours. She also complains of weakness in her legs, urinary incontinence, and difficult speaking. She has noticed a tremor in her right hand when writing and eating that has worsened over the past few weeks. Although she has had occasional tremors and troubled speech, her problems have never lasted this long and have never been accompanied by urinary incontinence or loss of vision. Upon questioning, she recalls that her mother had similar symptoms when she was young. Physical examination reveals left-sided facial droop, left tongue deviation, and lateral gaze weakness. Brain MRI is shown in the following figure. Next slide, we'll see it. Relevant laboratory findings are as follows. White blood cell count, 9,100 per cubic millimeter, which is nearly normal. Hemoglobin, 13.3 gram per deciliter, normal. Hematocrit, 37.1%, normal. Platelet count, 287,000 per cubic millimeter, which is nearly normal. CSF immunoglobulin G index is increased 0.98. The normal is below 0.66. What is the most likely diagnosis? Multiple sclerosis. Here is the MRI, magnetic resonance imaging of the brain. We see the lesions around the ventricular system, the lateral ventricle. They are marked by the arrowheads, and they are hyper intense signal on this flare sequence. What risk factors are associated with this condition? Risk factors for multiple sclerosis include the following. Age, 20 to 50 years. The mean age of onset is 30. Female gender. The female to male ratio is 1.77 to 1. Having grown up in a temperate, moderate climate. Family history of multiple. What anatomic features could explain the findings on clinical examination? A medial brainstem lesion involving cranial nerves number 6, 7, and 12 leads to the constellation of facial droop, tongue deviation, and lateral gaze weakness. The intention tremors present in this case indicates cerebellar involvement, as we see in this diagram or figure. The cranial nerves that lie medially at the brainstem are the 3rd, the 6th, the 12th cranial nerve. What are the typical CSF findings in this condition? Oligoclonal bands. These bands are seen in 85% to 95% of the patients of multiple sclerosis. The presence of these immunoglobulins reflects the autoimmune nature of the disease. The oligoclonal bands are not specific for multiple sclerosis, can be elevated in some other conditions like Lyme disease, lupus, syphilis, Sjogren's syndrome, and neurosarcoidosis. Similarly, the immunoglobulin G index is elevated in more than 90% of patients with multiple sclerosis. The total CSF white blood cell count is normal in most patients, but an elevated white blood cell count is non-specific. What is the likely finding on imaging of the brain? Multiple demyelinating plaques are usually present in the brains of patients with multiple sclerosis, especially in the periventricular region, corpus callosum, and centrum semioval, and appear by the magnetic resonance imaging of the brain. What is the appropriate treatment for this condition? Acute attacks are treated with high-dose corticosteroids. We call it intravenous methylprednisolone or IVMB. It's a mega dose of methylprednisolone. However, these drugs don't change the course of the disease. So the second line is a disease-modifying treatment, and the most common is interferon beta 1b. It binds the receptor and induces a transcriptional response that induces T cell proliferation and antigen presentation and alter the cytokine levels. Finally, supportive care, including the neurorehabilitation, is important in preserving activities of daily living. The second, an emergency medical team is called to help a 60-year-old woman with small cell lung cancer who is unconscious at work. Her co-workers state that for about 10 seconds before she lost consciousness, she pointed to her right hand as it began twitching rhythmically. Then muscles stiffened and fell down. After about 15 seconds, she became incontinent and her arms and legs began jerking rhythmically. She then was still unresponsive and unconscious for about 3 minutes. The medical team notes she is now breathing deeply but remains unresponsive. What is the first question? The first question is, what is the most likely diagnosis? Seizure. This is a seizure. Involvement of the left motor cortex is implicated because the seizure started with right-handed motor activity. In this patient, a metastasis is the likely culprit because the patient is having lung cancer. Seizures can also be caused by infection, ischemia, drug exposure, or withdrawal. Certain iron imbalances, including hypoglycemia and hyponatremia, in addition to head trauma. How is this condition classified? This is a simple partial seizure with motor signs secondarily generalizing into a generalized tonic seizure, tonic-clonic seizure disorder. So it's a partial seizure with secondary generalization. During the first 10 seconds, the patient maintained consciousness, pointing to a simple partial seizure. Complex seizures require loss of consciousness. After the first 10 seconds, her simple partial seizure evolved into a generalized tonic-clonic one. The tonic phase is characterized by the immobile contraction of all muscles, while the clonic phase is characterized by the bilateral rhythmic jerking of the extremity. Why is the patient breathing deeply after her incident? The patient is likely responding to acidosis. A respiratory acidosis can develop from the loss of coordinated respirations during the seizure, and a metabolic acidosis can develop as well, as muscles contract under anaerobic conditions and produce lactic acid. What is the appropriate treatment for this condition? Popular anti-seizure medications include valproic acid, phenytoin, phenobarbital, primidone, and carbamazepine. All can treat this condition. Many anti-seizure medications work by enhancing gamma-aminobutyric acid, GABA, binding on chloride channels. GABA binding allows chloride ions to flow into the neurons, thereby inhibiting neuronal firing. Barbiturates act on the same chloride channels and enhance GABA signaling by increasing the duration of chloride channel opening, while the benzodiazepines increase the frequency of chloride channel opening. What are the most common adverse effects of treatment? Adverse effects of seizure treatments are as follows. For valproate, hepatotoxicity, neutropenia, thrombocytopenia, teratogenicity, neural tube defects in the fetus contraindicated during pregnancy. Carbamazepine, hepatotoxicity as well. So we have to check the liver function. Aplastic anemia. So we have to check the CBC, granulocytosis also. Phenytoin, acute will cause ataxia, chronic will cause gum hyperplasia and teratogenicity as well. Ethosuximide and lamotrigine will cause Stevens-Johnson syndrome, which is a bullous form of erythema multiforme that involves mucous membranes and large areas of the body. It's one of the medical emergencies. It's a serious condition. Carbamazepine and phenobarbital, induction of cytochrome B450. So keeping in mind that there is a wide range of drug-drug interactions with many medications affecting the cytochrome B4. Case number 72-year-old woman is at home with her husband when he notices she sounds confused, even though she had been speaking clearly just moments before. He brings her into the emergency department where she is unable to follow commands. Her speech is fluent but doesn't make any sense. CT scan of the head is shown in this figure. Here, we have hyperdense signal, hyperdense signal in the thalamus, and extending into the ventricular system. What's the most likely diagnosis? It's a stroke, hemorrhagic stroke, intracerebral hemorrhage. The figure shows extensive intracerebral hemorrhage in the thalamus, the left arrow, and its extension into the third ventricle, the top arrow, ipsilateral ventricle, the bottom arrow, and the lateral ventricle as well, the right arrow. What risk factors are associated with this condition? Advanced age, cardiovascular disease, carotid disease, diabetes mellitus, dyslipidemia, family or personal history of TIA or stroke, hypertension, and smoking. What type of aphasia does the patient exhibit? The combination of fluent but nonsensical speech and poor comprehension is characteristic of what we call Wernicke's aphasia or sensory aphasia. These patients also display poor repetition and naming ability are poor as well. Other findings commonly associated with Wernicke's aphasia include contralateral visual field defects due to ischemia of the optic radiation and anosognosia, which is unawareness of one's deficit. A lesion in what anatomic area causes these findings? Wernicke's aphasia is usually the result of ischemia in the superior temporal gyrus, which is supplied by the inferior division of the left middle cerebral artery. What speech pattern results when this condition affects the inferior frontal gyrus? The inferior frontal gyrus controls motor aspects of speech, not the sensory aspect of the speech. A stroke in this area causes Broca's aphasia or motor aphasia, while Wernicke's aphasia is sensory aphasia. This Broca's aphasia is characterized by non-fluent agrammatic speech because of the proximity of the primary motor cortex of the face and arm, dysarthria, difficulty in articulating words, and right face and arm weakness are often associated with Broca's aphasia. Compensation is intact. The comprehension, is intact in these patients. If the patient had nail bed hemorrhages, nodules on her fingers and toes, and retinal hemorrhages, what diagnosis should be considered? Here in this case, the constellation of these manifestations suggests the infective endocarditis, which is characterized by splinter hemorrhages, Osler's nodules on the pads of the fingers and toes, and Roth's spots of the retina. Infective endocarditis can lead to the release of thrombi from the valvular vegetations resulting in embolic events. Case number 4, the last case, a 57-year-old obese right-handed man with a history of atrial fibrillation or AFib, and mitral valve repair is brought to the emergency department by a coworker who noticed the sudden onset of slurred speech and right hand clumsiness. The coworker denied seeing any seizure-like activity or loss of consciousness. The patient can converse appropriately and denies any recent head trauma. Physical examination reveals an irregular heartbeats and a left carotid burway. Neurological examination reveals grossly intact cranial nerves, with the exception of mildly decreased facial sensation on the right side. He has 4 to over 5 muscle strength and diminished sensation in the right arm. CT scan of the head is negative for bleeding or any mass lesion, and the patient's symptoms resolve spontaneously within 1 hour of onset. What is the most likely diagnosis? Transient ischemic attack. Classically, transient ischemic attack has been defined as stroke-like symptoms that resolve within 24 hours. However, increasingly sensitive imaging techniques of the brain have helped refine the definition of TIA. Now, it is defined as focal neurologic symptoms that last less than 1 hour, with no evidence of ischemic changes on radiological studies. What's the most likely cause of this patient's condition? This TIA is most likely caused by an embolic stroke, as the patient has several risk factors for emboli. Carotid stenosis, usually from atherosclerosis, which can be a source of emboli, history of atrial fibrillation, which can be exposed to embolus formation, mitral valve repair, which can harbor vegetations that may embolize. What findings on the CT scan of the brain suggest the presence of cerebral edema? Signs of cerebral edema on the CT scan of the brain include loss of the gray matter, white matter junction, loss of the prominence of sulci, and evidence of a mass effect such as midline shaft, decreased size of the lateral ventricle on the affected side, and ankle herniation of the ankles of the temporal lobe into the foramen magnum. What is the vascular distribution of the 3 major vessels supplying the cerebral cortex? The anterior cerebral artery, middle cerebral artery, and posterior cerebral artery are the 3 major vessels supplying the cerebral cortex. The anterior cerebral artery branches off the internal carotid artery and supplies the medial portion of the motor cortex, the sensory cortex, and the majority of the frontal lobe. The MCA, middle cerebral artery, also stems from the internal carotid artery and supplies the lateral portion of the motor cortex, temporal lobe, and the somatosensory cortex. The BCA, or posterior cerebral artery, stems from the basilar artery and supplies the visual cortex as well as the posterior parietal lobe. Here, this illustration or diagram showing the lateral view, medial view, and inferior view of the brain. The anterior cerebral artery supply these areas in the light blue, and middle cerebral artery in the yellow color, and the posterior cerebral artery in the light red coloration. What findings differentiate strokes due to occlusion of each of the 3 vessels? Stroke symptoms correspond to the vascular distribution of each artery. A stroke of the anterior cerebral artery results in lower extremity deficits. A stroke of the middle cerebral artery results in face and the upper extremity deficits. And a stroke of the posterior cerebral artery results primarily in visual deficits. Thank you.